Good evening, everyone. And as we know, airway management in the ICU is not just about anatomy anymore. It's about physiology, timing, decision making under pressure, and anticipating deterioration before it happens. Unlike the control OT environment, a critically ill patient gives us no second chance. Hypoxemia, hemodynamic collapse, acidosis, these are the varied enemies. Today's discussion will focus on practical bedside decision making, what really works, what doesn't, and what we must rethink as an intensivist. It's my privilege to introduce Professor Sheila Nainan Myatra. Is a name synonymous with excellence in airway management, hemodynamics, and critical care. She's been at the forefront of advancing safe airway practices with significant contribution to research, education, and guidelines that many of us follow in daily practice. A leading authority in airway management and critical care, she's been a past president of ICCM, and today she'll be speaking on beyond intubation, airway management in the critical ill, a topic that perfectly aligns with the evolving challenges we face in the ICU. Once he's done with this, we'll have the panel discussion with the eminent panelists. I'll introduce them in detail once we start with the panel. Over to you, Professor Sheila Mehta.
Hello, everyone. Good evening. And thank you, Bharat, for that very, very kind introduction. And thank you for choosing this topic that is really very relevant to the intensivists and also to the anesthesiologists. And often anesthesiologists who practice intensive care also look at airway management as an extension of what they do in the operating room. So this talk kind of highlights what I'm going to put you through. I'm going to talk about the high risk of rate of complications that occur in the critically ill patients, and also talk about some strategies that we could utilize to mitigate these risks. So just to contextualize the airway management in the critically ill, and these are complications of tracheal intubation in the critically ill patients. These are the large series that are available in the literature, and as you can see, the incidence of hypoxia, hypotension, cardiac arrest, what you see in pink, is significantly much higher in the critically ill patients as compared to what we see in the operating room. And we have a recent multi-center Spanish study and also Brazilian study showing equally high number of complications. Now, as an anesthesiologist, I have the opportunity of looking at airway management in the operating room and in the intensive care unit in the same period of time. And I've often wondered, why are complications related to airway management in the critically ill patients so high? And in my mind, there are three fundamental differences between airway management in the two places. One is the ICU environment. So the ICU environment itself is a very complex environment. Those of you who work at both places, you can see what control conditions we have in the operating room. In the intensive care unit, just getting to the head end of the patient is such a challenge. There's so much clutter around the bed. There's an ultrasound machine, a crash cart. It may be any time in the day or night. You don't have all the tools in your armamentarium. And, I have a patient who's coming to me who's in septic shock. So I not only need to manage the airway, but I also need to look after the hemodynamics. The ICU environment itself makes airway management a very complex procedure in the intensive care unit and increases risk of complications. The next is the operator factors. So in the intensive care unit, we have varied levels of expertise with airway. Not all are anesthesiologists whose core competency is airway management. You have varied levels of skill, junior residents, seniors who are doing airway management, and not much help around. So the experience of an operator also makes a big difference to the safety with airway management. And most importantly, the patient. This is not the fasted patient who comes optimized for surgery. This is a critically ill patient. And we know that often there is an imbalance between oxygen delivery and consumption in these patients. There are many factors that increase the consumption in critically ill, which you are well aware of. And there are various factors that decrease the delivery of oxygen. So you often start with an imbalance between oxygen delivery and consumption. Now, you may have seen the Benioff curves. And when you look at a normal patient, okay, this is on the x-axis, you see the time to desaturation. On the y-axis, you see the oxygen saturation. And this is the time to desaturation after you give a muscle relaxant when you perform an RSI. And unlike in the normal patient, what you see in the critically ill patients is they already start with a low FRC. And as I mentioned, they have high oxygen consumption. And these patients rapidly desaturate during the period of apnea. So they have what we call a shorter apnea time than normal patients, and that is the time to desaturation is much faster. So you're already starting with a disadvantage when you're looking at, these are really high-risk patients when you're doing airway management in these patients. And this was an article review that was written, led by Dr. Diwatia, and I was also fortunate to be a part of it. It published in Indian Journal of Anesthesia. which was titled "Tracheal Intubation in the ICU: Life-Saving or Life-Threatening." And I think this summarizes this high-risk procedure very well. This is a life-saving procedure that we do often in the intensive care unit, but this life-saving procedure can turn into a life-threatening condition if it's not managed carefully. Now, I want to just give you this clinical scenario to contextualize what we mean, the kind of airway management we're talking about in the physiologically difficult airway patients. 60-year-old male, acute hypoxemic respiratory failure in the intensive care unit. He's being intubated for worsening hypoxia. He's delirious. He's already on BiPAP, 100% FiO2. Airway examination is not possible. The patient's saturation is 88. Respiratory rate is 42, very tachypneic. Heart rate is 120. BP is high. Fasting state is unknown, and labs are grossly within normal limit. And of course, a rapid sequence intubation is planned for this patient, and RSI is done. Propofol is given. Rocuronium is 70 milligram is given, and video laryngoscopy is used. Nice grid 1 view. Endotracheal tube is passed through the cords. Nice waveform capnography. RSI was conducted. Tube is inserted successfully, and everything looks very good to go. And what do you see next? The patient's blood pressure is 60 by 40. End-tidal CO2 drops from 30 to 15. You're pushing mephedrine. Patient becomes pulseless, and CPR is initiated. Of course, it's not always so dramatic, but very often we do see such precipitous fall in blood pressure when you're trying to intubate the patient. Even if your tube has gone in successfully, you see other complications like hypotension. Now, as airway managers, we are obsessed with, anatomical difficulty. All our scoring systems talk about anatomical difficulty. And when we talk about airway management, we are always obsessed with anatomical difficulty. We think, where will we be able to deliver the tube, and what are the anatomical factors that make tube delivery difficult? But these patients have what we call a physiologically difficult airway. This is the altered physiology or the pathophysiology in these patients that increase the risk of complications during airway management and transition to positive pressure ventilation. So these patients have a physiologically difficult airway, and these are the steps of a rapid sequence intubation. And if they also have an anatomically difficult airway, then this further increases the risk of hypoxia and hypotension. And this is what we have to be very cognizant about. Now, I talked about anatomically difficult airway scoring systems. So what about scoring systems for patients with a physiologically difficult airway? And one that is validated and commonly used is a Makocha scoring system that comes from France, from the group Montpellier group with Audrey de Jong and Samir Jaber. And Makocha stands for the following: M for Malampati, A for apnea, cervical spine limitation, mouth opening, C for coma, hypoxia, and anesthesiologist non-trained. And if you look, it has a 12-point scoring system. And if you look at this score, it not only looks at anatomical factors, but it also looks at physiological factors. If your patient is comatose, or if your patient has severe hypoxia, you get 1 additional point. In addition to this, and I like this very much, if your operator is not an anesthesiologist, you get 1 additional point for 1 additional risk factor score. And the higher the score, the higher is the difficulty in intubation. This was suggested by the Montpellier group, and this has been validated for use in the intensive care unit. We also have the other scores that have been described, like the HIP score, but the Makocha is the most widely used and popular score. And then if you look at the Montpellier intubation bundle, they are the first to talk about the intubation bundle, and they give the pre-intubation, peri-intubation, post-intubation bundle. And one of the things that they talk about is, in the first part of the bundle, is you have 2 operators. Whenever you do airway management in a critically ill patient, you should have 2 airway operators, and at least 1 should be an experienced airway operator. And this is really important, because it's not like in an operating room where you can call someone from the adjacent operating room. Often you might be the only 2 people in the intensive care unit. So it's important to have someone else beside you when you're doing an airway management in the patient, and not just proceed, straight away trying to intubate the patient. Now, again, to put this into, see where we are today, and I want to allude to the Intube study, and this was published in JAMA in 2021, and I was really fortunate to be the co-lead on this study with Vincenzo Russotto from Italy and Giacomo Bellani. And all the studies that I showed you until now were single center studies, or they were national audits, and most of them coming from the Western world. So we didn't really have any data from the developing world. How were patients being intubated, critically ill patients being intubated, and what was the risk of complications? So this was a prospective observational study, and many sites from India participate. Second highest number of centers. We had over 60 centers participating. And for this, the data was from 29 countries and close to 3,000 patients. And this was, as you can see, from the developing world and the developing world. And what we looked at is, the primary endpoint was a composite of at least one of the following events happening at 30 minutes after tracheal intubation, either severe hypoxia, cardiac arrest, or cardiovascular instability described by the following criteria. And this is with immediately 30 minutes after intubating a patient who's critically ill. And I'll just give you the, just the overall results very quickly to contextualize this. So, not surprisingly, the primary, the endpoint, which was a complication, the overall complication was 45%, which is almost 1 in 2 patients who have an airway managed, tracheal intubation in a critically ill has one of these complications. But what was interesting that it was not hypoxia, which we always worried about, but hypotension. The INTUBE study was the first study that revealed that the incidence of hypotension is really high, 42%. Again, almost 1 in 2 patients have hypotension following tracheal intubation. And the hypoxia that we're always worried about not being able to deliver the tube was 9.3%. Perhaps over time, we have become good at peri-intubation oxygenation, and we really miss that big complication that occurs is hypotension. And cardiac arrest was about 3%. Now, an important finding from this study was this was the first study that looked at 28-day mortality. Until then, we looked at immediate complications. But what this study showed that if you had an overall outcome or cardiovascular instability in these patients, this increased the 28-day mortality. Patients who had this had higher day mortality. Now, this is a very important finding because it actually means that we should try to prevent rather than just treat these complications. When these patients have hypotension, we give a vasopressor, or when they desaturate, we reoxygenate them, and we think we're fine. But if these complications occur, you have an increase in 28-day mortality. So really, really strong message to prevent these complications. Now, I've talked about the physiologically difficult airway. Now, this is not a new entity. It's always been there, but it was first highlighted by these two individuals, Jared Mosier and John Sackles, who come from the emergency department. They from the United States, and they highlighted this entity, physiologically difficult airway. Think about the physiologically difficult airway, and they talked about only critically ill patients and critical illness that altered pathophysiology that increased the risk of complications. And then the in the airway community, and along with Dr. Divatia and Dr. David Brewster, we wrote this review in Current Opinion, the physiologically difficult airway and emergent concept. And we said this is not only about critically ill patients, and this is about all patients who have altered physiology and anatomy, and it extends beyond just critically ill patients. We're talking about obese patients, we're talking about obstetric patients. There are more patients who have a short apnea time because of altered physiology, and this is a very nice review in which we address this. And we said the time has come to define what a physiologically difficult airway is, and also to have consensus, global consensus among experts as to how should these patients be managed. And we don't have very robust data for a lot of the interventions, and that's therefore the next best thing to do is to have a consensus Delphi, and that's what we did. We took global experts in critical airway management in critically ill patients from across the globe, both from high and low resource settings, good diversity. And what we looked at, we said, okay, and a very robust consensus Delphi process was conducted to get consensus not only on the definitions, but also on various interventions for tracheal intubation in the critically ill patients. And I really urge you to read this paper. It's published in Intensive Care Medicine, and I'm happy to share it with you. And it has very nice expert consensus statements on every part, right from the definition until the post-intubation care. And I'm going to give you a very quick summary in the next 5 or 10 minutes, starting with the definition. So what John Sackles described was the pathophysiological alterations, but we said a physiologically difficult airway constitutes not only the pathophysiological alterations like hypoxia, cardiovascular instability, right ventricular failure, even raised intracranial pressure. You have a brain injured patient with a raised ICP, you try to intubate him, you can actually worsen the complications unless and increase the ICP further unless you take precautions. And also physiological alterations like pregnancy, obesity. These patients also have reduced FRC, also have a short apnea time, and they also have what we call a physiologically difficult airway. Now, coming to pre-oxygenation and apneic oxygenation. So I'm going to very quickly describe a few strategies that we could use to mitigate this high risk. And I think I've really contextualized how what a high risk these patients carry, both with a physiologically and also perhaps an anatomical difficulty that they may possess. So pre-oxygenation and apneic oxygenation becomes paramount. Now, we have 3 tools in our armamentarium for pre-oxygenation. You can do it either with a face mask or what we call COT, conventional oxygen therapy, or high flow nasal oxygen on NIV are newer tools in our armamentarium, which we could use to pre-oxygenate them prior to tracheal intubation. The advantage of HFNO and NIV is that we can give PEEP to these patients. With high flow nasal oxygen, if the patient keeps the mouth closed, we can give PEEP to these patients. So, what is the evidence with this? So, this is a randomized controlled trial. It was published in NEJM recently in 2024. NIV compared with pre-oxygenation using conventional oxygen therapy. And one would wonder, do you really need a randomized controlled trial? Wouldn't NIV be superior? And rightly so. The primary outcome in this study was hypoxia, and during intubation, and was significantly lower in those patients who got NIV. So this study concluded that in critically ill patients, NIV resulted in lower incidence of hypoxia when patients were pre-oxygenated using NIV as compared to the oxygen mask. Now, what about a head-on comparison with the NIV and high flow nasal oxygen? And this was first done by the Florali 2 study. This is a multi-center study done in France. And what they did is non-invasive ventilation versus high flow nasal oxygen. So in one group, they pre-oxygenated with non-invasive ventilation. And in the other group, they gave high flow nasal oxygen that for pre-oxygenation, which was continued during attempts at intubation. And the primary endpoint was saturation going less than 80 during intubation procedure. And what they found was there was no difference between the two groups. But what was very interesting is that in the subgroup of patients in whom the PaO2 FiO2 ratio was less than 200, NIV was superior to high flow nasal oxygen, probably because of a more definitive delivery of PEEP and higher PEEP that can be given with NIV. So in moderate to severe hypoxia, NIV seems to be better. And now we have the meta-analysis of all the studies looking at pre-oxygenation for tracheal intubation that is done by the Canadian group of BAM, Rochefort, and all the methods published, 15 eligible studies, almost 3,500 patients. And what they found is clear superiority of high flow nasal oxygen and non-invasive ventilation. And they concluded that pre-oxygenation with NIV or high flow nasal oxygen rather than face mask prevents hypoxia during tracheal intubation. And compared with high flow nasal oxygen, NIV probably decreases the incidence of hypoxia during intubation. So in the moderate to high risk, probably there is a role. And along with Sabir Jaber, I wrote the editorial for this paper, Pre-oxygenation for tracheal intubation adults who are critically ill, time to abandon the face mask. So I think the title of this paper gives the real message that today in a critically ill patient, when we're intubating them, we should abandon using conventional oxygen therapy and move to more superior forms of oxygenation like high flow nasal oxygen and PEEP. What about cardiovascular collapse? Okay, so I've often wondered that why do patients have so much hypotension when you're doing tracheal intubation? We're always worried about hypoxia. So there are many contributing factors. One is the critical illness itself. They have sepsis, cardiac dysfunction, hypovolemia, various factors. Sometimes they may already be on vasopressors coming for intubation, but the drugs that we use also cause hypotension: propofol, benzodiazepines, opioids, the loss of sympathetic drive. And this is really important. If you see the patient that I talked about, the patient was very tachycardic and the blood pressure was very high. So these patients have a very high sympathetic drive. The patients who come to you in acute hypoxia respiratory failure, very tachycardic, high blood pressure. And the moment you anesthetize with propofol, they were often already hypovolemic. They have precipitous fall in blood pressure. So it is the sympathetic drive keeps their blood pressure up and gives you a false sense of security. And you think, oh, wow, the blood pressure is fine. But the moment you anesthetize them, they have this precipitous fall in blood pressure. And then the positive pressure ventilation, they're already hypovolemic. All this hypotension occurs after intubation. And the reason being, you intubate them, they're hypovolemic, you give positive pressure ventilation, and there's already decrease in the venous return and further decrease in the cardiac output. So there are many factors. It's multifactorial, not one reason that causes it. And we've been cognizant about the drugs. And for the last 20 years, in critically ill patients, we use ketamine or etomidate because they're relatively more cardiostable. And there are multiple randomized controlled trials comparing these drugs. And we have several meta-analyses. And the most recent one that compared etomidate and ketamine for tracheal intubation, did not show any difference when they were used in the incidence, and this was looking at 28-day mortality. However, interestingly, the patients who got etomidate has little lesser in the secondary outcome. They had lesser hypotension as compared to the ketamine. That was an interesting finding. But the important message is that it should be either ketamine or etomidate for tracheal intubation unless contraindicated. Now, we were really concerned about this Intube study showing 42% of hypotension. And what we did is we did a secondary analysis, and we published this in the American Journal of Respiratory Critical Care Medicine. We took all those patients who had hypotension, cardiovascular collapse, so 42% patients, and we did a multivariate analysis, and we tried to look at what was the factor that caused hypotension in these patients. And very interestingly, we found that the use of propofol for induction was identified as a modifiable intervention significantly associated with cardiovascular collapse. And you know what? The anesthesiologists were the biggest defaulters because they were the ones who used a lot of propofol, whereas the emergency department and the physicians did not use etomidate or ketamine. So we often look at airway management in the ICU as an extension of our practice in the operating room. We don't like to use ketamine. Ketamine is a drug drug we've thrown out of the operating room almost 20 years ago. And we have other drugs which blunt airway reflexes really well, like propofol. So we like to use propofol, but it's not the same to use propofol in these patients as opposed to critically ill patients. And an important finding in this study was that irrespective of the starting blood pressure, propofol transitioned to hypotension. So I'll tell you my practice. When I had a patient who had a normal blood pressure, like the patient I showed you, I would use propofol. And if the blood pressure was low, then I would use ketamine. But now I've changed my practice and I avoid using any propofol in these patients and choose either ketamine or etominate for these patients. Another strategy developed in the, talked about is the fluid bolus. We know there's hypotension after intubation. So a lot of people give fluid bolus prior to tracheal intubation in the critically ill, but this had never been tested in a randomized controlled trial. So it was a Vanderbilt group who did the first RCT, 337 patients. In one group prior to tracheal intubation, they gave 500 ml of fluid bolus, normal saline. In the other group, they gave no fluid bolus. The primary endpoint was cardiovascular collapse. And what they found was administration of fluid bolus did not decrease in overall incidence of cardiovascular collapse. And this is something we have been doing, to prevent the hypotension, but doesn't seem to be making any difference. But the interesting point was that in this study, in those patients in whom, who received positive pressure ventilation, that means who got NIV or gentle mask ventilation during, RSI, those patients had a benefit from fluids. So they did another study, the PREPARE-2 study, and here they took all patients who received positive pressure ventilation, and in them they gave either fluid bolus or no fluid bolus, and almost 2,000 patients, big randomized controlled trial. But if you look at the cardiovascular collapse, which was the primary endpoint, no difference between the two groups either in. The hypotension is real. We have 42% hypotension. A fluid bolus doesn't seem to be making a difference. So perhaps there is a role for giving a low dose of vasopressor to prevent rather than to just treat these conditions. There are two trials underway. One that has just been completed in the Tata Memorial Hospital, which we're publishing soon, is the FLUA trial. I'm still not convinced fluids don't make a difference. So on one arm, we've used fluids. The other arm, we've used vasopressors. And we're talking about norepinephrine, 0.08 microgram per kg per minute, given through a peripheral line because the central line may not always be present, and given 10 minutes before induction. And continued up to 5 minutes after intubation. That's when the hypotension occurs. And the other group, we've given a fluid bolus. And in the other group is the other study is a prevention trial. Sure. And this is a study that is being done by the European Society of Intensive Care Medicine. I'm part of the steering committee of this study. And here they're doing usual care, using usual care in one arm, and the other arm they're using norepinephrine. So the results of these trials will tell us very soon about a very important unanswered question in airway management in critically ill patient as to whether there is a role of giving a low dose of vasopressors prior to intubation to prevent this serious complication that occurs. So coming very soon to video laryngoscopy and the benefits of video laryngoscopy, it really changes not only the view from me to we, but also the cognitive load. There's huge cognitive load when you cannot see something, you don't know what you're doing, somebody coming over your shoulder, what can you see, what can I see? It really changes everything because there's someone else who's sharing your stress, telling you what you can do. So it's really a game changer in airway management. But many studies did not show any, meta-analysis also did not show any improvement. While in the operating room, there was a huge benefit seen in even the meta-analysis showing that video laryngoscopy is superior to direct laryngoscopy. Similar findings was not seen in the critically ill patients. Now, getting a great view does not mean that you will have a successful intubation. A video laryngoscopy will give you a great view. The challenge is not to get the view. The challenge is to know how to deliver the tube. And that's why it needs a lot of experience. And remember, a great view will never give you a successful, not necessarily give you a successful intubation, because your line of sight, unlike in direct laryngoscopy, the tube is not going in the same axis, right? So you're getting an excellent video imaging, but the tube may not go. And that is why it's very important to use tools like a Stylet or Bulgy to deliver the tube, and training is very important. So if you see the previous meta-analysis, no difference, whereas in the operating room, huge difference. And this is because of the experience of the operator and also the time taken. When you take a lot of time in the operating room, it's okay. It's, you can go ahead and do a second attempt, but in a critically ill patient, it's not very forgiving. And now we have the, the large randomized controlled trial, the device trial that has really nailed it because it's shown clear superiority of video laryngoscope versus direct laryngoscope in a large, adequately powered study. And today, the real message is every ICU should have a video laryngoscope with people trained to use it. And, we should use it as at the first instance for first pass intubation success. And you also have a meta-analysis now, which clearly shows superiority of direct video laryngoscopy over direct laryngoscopy. So I'll talk about the last part, and this is esophageal intubations. And unlike in the operating room, when we have esophageal intubation, we just remove the tube, we reoxygenate the patient, and we you give the junior trainee another attempt. Even a single episode, and this is an old study from Mott, high incidence of hypoxia. You can see when you have an esophageal intubation versus when you don't, and you have different types of complications that can occur during airway management, significantly higher complications. And if you have more than two, it can be catastrophic. So the important message is you must use capnography to exclude esophageal intubation. Very few ICUs use, capnography. And the national audit project that was done, more than 10 years back, and this is, they looked at airway management complications in the intensive care unit, and they also looked not only in the ICU but also in the peri-intubation areas, outside operating room. And this is a subgroup of data from the ICU. So 184 complications. More than 60% of the events led to death or brain damage. Most of the events that occurred outside hours, managed by doctors with less anesthetic experience, and led to permanent harm. And the very important message is that failure to use capnography contributed to 74% of the cases of death or persistent neurological injury. And this study, this subgroup of ICU patients really highlighted the importance of using capnography in the intensive care unit. And I'll go back to the Intube study, and I'll show you that, firstly, the use of video laryngoscopy, 17% were only using. And this isn't data from the developing world. It is also only from the developing world, where you can say maybe video laryngoscopy was not available. This was also from the developed world. Now, this was an earlier study. So hopefully after the device trial, the video laryngoscopy use rate will go higher. But what was most disturbing is almost 60% of the people are still using auscultation to confirm tracheal intubation, and only 1 in 4 of the airway operators are using capnography to confirm tracheal intubation. So this is a very, very serious thing. 10 years after the national audit project, which highlighted the importance of using capnography in the intensive care unit, only 1 in 4 people are using capnography. And this is also the story of the developing world. So we have a lot of work to do to enhance safe airway management practices. You may have heard of the Puma group, which is a group looking into universal airway management practices with anesthesiologists, ED, and intensive care. I'm very proud of being part of this 14-member group. And we came up with this paper, which we published in Anesthesia, and these were guidelines for preventing an unrecognized esophageal intubation. Now, you would wonder, do you really need a guideline for this? And esophageal intubation, unrecognized, would never happen to me. A very good paper, useful to read. And we were urged to write this after 2 deaths that occurred in the UK and also in Australia because of missed esophageal intubation. And several recommendations, the 2 key recommendations was you use end-tidal CO2 and use ventral whenever available to prevent this. And a very nice graphic given in the paper that I really urge you to look at. And we talk about seven consistent traces of continuous waveform capnography with no decline. And if you have a very stormy intubation, a lot of air going into the stomach, and your tube is in, and you connect to capnography, you will see a waveform. So people respond to 2 or 3 traces and say, the tube is in. But this is not acceptable, and you will see a decline. So either something going up or something, but you need to look for 7 traces before you declare that the tube is in the right place. And we have to be very careful about this. One is to use capnography and also to use it in the right way. Now, I'll end by talking about guidelines, and I'm really proud to say that the first guideline for tracheal intubation in ICU in the world came from India. It came from the All India Difficult Airway Association and was published in 2016 in the Indian Journal of Anesthesia. And I was very happy with Dr. Divatia to lead this guideline. And we had a very comprehensive algorithm for addressing a failed airway. And that was in 2016. And in 2017, the French Airway Society came up with guidelines for intubation and extubation in critically ill. And in 2018, the DAS came up with guidelines for tracheal intubation in critically ill patients. So in 2 years, we had 3 guidelines for tracheal intubation in the critically ill patients. And this is just highlighting the importance of this entity and the need for different specific considerations for this high-risk group. And I'm also happy to say that this year, we are updating our guideline after 10 years on tracheal intubation in critically ill patients. So I leave you with these concluding remarks that anatomy, of course, is important and we're often focused on it, but altered physiology is the real danger during tracheal intubation in critically ill patients. And the physiologically difficult airway is one in which pathophysiological physiological and physiological alterations in the patient increase the risk of complications during intubation. Hypotension and hypoxia are the most common complications, but remember, hypotension is really, really common, and it's something we're not, we have to be aware of. And there is a higher risk of mortality at 28 days from intubation in patients experiencing complications. So it's important to prevent and not just treat these complications. And while we have good evidence for some of the interventions, and we have consensus through this Delphi for most of them, future trials will need to address the remaining uncertainties for airway management. And again, I'll leave you with this line that tracheal intubation is a life-saving procedure. And this life-saving procedure can turn into a life-threatening situation. You're intubating the patient to save his life, but the intubation itself can kill this patient unless you manage this properly. I'll leave you with the infographic from this paper. And with this, I thank you very much for your attention. I'm happy to take questions. Thank you.
So thank you, Professor Sheila, for that outstanding and deeply insightful talk. We'll go through the panel next, and then as the questions comes in, we'll also take across the panel. And you have beautifully highlighted that airway management in the critically ill goes beyond algorithm. It's about understanding physiology, anticipating deterioration, and making decisions in real time under pressure. So I particularly liked your emphasis on physiological airway, the definition which is common, hemodynamic optimization, and use of the induction agent, and that sets the perfect stage for what we are here about to discuss next. And I have an excellent panel with me. Allow me to share my slides. So, and I'll try to keep this interactive, practical, and clinically relevant. So, as introduced, we have with us Professor Sheila Mehta. She's also one of the panelists and past president of Indian Society of Intensive Care Medicine, chair Intensive Care Medicine, immediate past president of All India Difficult Airway Association, and member of the Surviving Sepsis Guideline. And she's developed a new test. We all know about the tidal volume challenge. Then we have Doyen in Critical Care, Professor and Head of Critical Care Department, Leelavati Hospital. That is Dr. Jiggy Divatia. He's our mentor and has quite a bit of achievements. He's Editor-in-Chief of IJCCM, past President of Indian Society of Anesthesiology, past President of ISCCM, past Editor-in-Chief of Indian Journal of Anesthesiology, over 280 publications with H-index of 45, and his area of interest are hemodynamics, critical care, and airway. Then we have Dr. Saeed Moeed with us, presently Vice Chancellor at Al Karim University, Bihar, Editor in Chief of Journal of Resuscitation, past Editor in Chief of Indian Journal of Anesthesia, lead author in designing the Indian Resuscitation Guidelines, and many more accolades. And we have Dr. Tanmay Tiwari. He's professor additional from Department of Anesthesia and Critical Care, that is KGMU Lucknow, and his area of interest are airways, solid organ transplant, and medical gas support. Major achievements: Honorary Secretary ISA UPA. He's been past Secretary of ISA Lucknow, and he's received awards of Scholar WFSA, that is in 2021, has more than 50 publications with more than 240 citations. Then we have Dr. Madhuri Kudri. He is Professor and Department of Anesthesiology, Karnataka Medical College and Research Institute, postgraduate teacher since 29 years, PG examiner, Editor-in-Chief of Indian Journal of Anesthesia. So we have quite a bit of editors-in-chief, and the first guideline, as was spoken about, Dr. Sheila also brought it out. It was, that is tracheal intubation of critically ill, came from the India, and it was published in IJA and then republished in IJCCM. So let's move towards the concept and risk stratification. And Professor Sheila, this is for you. So traditionally we focus on anatomically difficulty. Always we talk about malampati, mouth opening, neck mobility. But in ICU, real challenge is also physiology. So how should we reframe our thinking about physiologically difficult airway in ICU patients?
Yeah, so thank you for this question. So I think, like what John Sackles and Jaron Mosier did was, this entity was always there. Okay, critically ill patients, we knew complications were high, but what they did is they brought the focus to this by coining this term physiologically difficult airway. And, our obsession is with technical delivery of the tube to get the tube in somehow. But we tend to ignore that these patients, because of their altered physiology and pathophysiology, have, will deteriorate and have complications and at a high risk of other things that will happen. So we should not just worry about the hypoxia with not able to technically deliver the tube, but many other physiological and physiological alterations that can pose a danger. And this is why it's really important that we should Sometimes, like you say, why do you need a Women's Day? Every day should be Women's Day. The same way, it's important to coin a term, physiologically difficult airway, to move the focus from just anatomy to physiology. So I think this is really important, and all intensivists and all airway operators should be aware of this entity, even anesthesiologists, because you may have a critically ill patient coming to the operating room for an emergency surgery. So you have to be aware of this entity, the physiologically difficult airway.
Thank you very much. And we move towards the second question, that is for Dr. Madhuri. It's for you. So we have scores like Makocha, Hypes, but at the bedside things are messy. What do you actually rely on? You really look into the scores, experience, or pure clinical just?
Yeah, I think I don't know how many of us are using the scores. But the as Sheila Madam has already told about the Makocha score and the hype score and the other clinical judgment. The Makocha score, as she has already told and described, I will not be explaining that. But the Makocha score takes some time to it takes some time to do that scoring because of the several parameters which are involved in there in that score. And the other score, that is the hype score, it takes less time compared to the Makocha score. So what is usually done is that if there is less time, you go to the hype score, and if you have a little more time, you can go to the Makocha score. But whatever done, these scores cannot be used alone. You have to complement these scores with the clinical gestalt, which means that you have to use your clinical judgment and the overall impression of the anatomy, the severity of the illness, take the history of prior airway problems, and see the physiological reserve of the patient, and then you take a call. So it is not just the scoring, but you have to complement it with the clinical judgment.
So very nicely put it across. Uh,
Can I add
please,
something to
please.
this,
Yes,
Dr. Bharat?
yes.
If I given, see, my point is, see, in ICU, the window periods is very less. You hardly get time. The patient is at times willed in, where the patient is uncooperative, drowsy. You'll not be able to give. He'll not give you time to go for an assessment. The point is that when these patients are really willed in a conscious state, it is always better that you do an assessment there and document it in the case sheet. Because at the time when you're asking the patient to go for an NIV trial, by the time the patient goes for a trial for 2 hours, and then subsequently you see that the patient needs to be intubated, where the patient does not give you time to go for an assessment. So that's the time we need to do an assessment, document it on the case sheet, so that subsequent player can at least know that what were his assessment at the time of intubation. I mean, during assessment. So the most important thing before we go for all this assessment, get the assessment done when there is a window period when the patient is conscious, and document it in the case sheet. So this is more important when you talk about assessment. Thank you.
Uh, so nicely put it across. And now, as we move towards the third question, that is for Tanmay, it's for you. So in critically ill patients, we all are taught about the first pass success is critical. But in ICU, should physiology sometimes take priority over rushing for the first pass success? And should we be delaying intubation to optimize the patient, or we should just go ahead and look for the first raptor? And sometimes it could be harmful as well.
So I think, sir, thank you for the invite. And I think Dr. Sheila ma'am has already summarized that in the age of ICU, when we are dealing with a physiologically difficult airway, our focus should not only be restrained only to the anatomical visibility and just to get the tube inside. The tube, as we are trying to secure the airway, the first and the foremost thing is that we are not doing any harm to the patient. So if the airway management leads to any kinds of crisis in terms to the patient's health, then we should always delay and optimize our patient's priority should be related to the patient's optimization before doing any kind of airway intervention as the primary focus. So once we deal with the optimization and we try to get the patients better because we know that physiologically difficult airway patients are always very critical to handle. So they succumb to the cardiac arrest, and they lead to a lot of difficulty if we only focus on the airway. So my point would be that we should try to optimize, and then we should try to execute. And the the take-home message should be that we should try to individualize for each of our patients, and we should try to optimize our patients before we actually go for the management of the airway.
Yeah, Bharat, if I may
Yeah,
just
please,
add, yeah. So Tanmay has put it very nicely that, we shouldn't rush to intubate and we should really try to optimize these patients prior to intubation, because sometimes we think it's so emergent and we're just obsessed with getting the tube in fast, but that can result in dangerous company. But one thing I want to tell you, and that really makes me feel a little sad about all these trials that look at airway tools in critically ill patients, intubation, the primary endpoint is first pass intubation success. And I think this endpoint is wrong, because the goal is not, I don't want to have my tube in first pass, but with my patient having a cardiac arrest. So I think what the endpoint should be, and we've written about this, we published it, that this is a wrong endpoint to use. We should have a composite endpoint of first pass intubation success without complications, because that is important, right? We don't want to just have a first pass intubation success as would be in an operating room where the complication rates may be very low. So here, this, I would be very happy if future trials looked at first pass intubation success without complications. And I think that's the area in which, this has been highlighted in the airway community, that this is what the research, because if you look at even the device trial, which looked at video laryngoscopy versus direct laryngoscopy, again, they were using first pass intubation as their entry point.
As we teach our students, the priority should shift to the area of physiologically difficult airway. Many of our residents usually don't get into the physiologically difficult airway. So it's very new term for them, and they don't gel to that comment very easily. So our process should be that we should try to build a focus on the physiologically difficult area.
But Tanmay, my point is your students are already facing emergency, cases as well. So in emergency cases, these patients already come with a physiologically difficult area because they are the hypotensive, they are hypoxic, they are having bulk trauma, abdomen blunt, and chest injury. So they are already, so they just need to tell them the scenario that what are the scenarios which you can get physiological difficult area. Yeah. Yes, sir wants to say something.
Yeah, Jiggy sir.
Yeah. So Bharat, I'm absolutely in agreement with Dr. Sheila that the focus should be on first pass without complications. But I think we also must recognize that in the ICU, in the setting of the physiological difficult airway, first pass success is linked to physiological complications as well. So in other words, if you're not able to get the tube in at first attempt, you are more likely to have complications than if you get the tube in at first attempt. So like Dr. Sheila mentioned in her talk, you should make every attempt to get the tube in at first attempt as fast as possible, whether it's by video laryngoscopy, using a stillet or a bougie, at the very first attempt and not as a second attempt after your first attempt has failed. So I think we must be very, very cognizant of the physiological difficulty. And one of the ways to avoid physiological difficulty is to get your tube in at first attempt. That is not the same as rushing into intubate, as what Dr. Tanmay and Dr. Sheila was saying. Every patient, large number of patients in the ICU who need intubation do not need to be intubated stat. There's always some time, maybe a few minutes to give some oxygenation going, get some.
Most of the cases we have time.
Yes, most of the times you have time, at least 10, 15 minutes you have time. Where only the odd case where we just rush in and intubate, it hardly doesn't happen very often. So I think we must distinguish between rushing into intubate, optimizing the patient prior to intubation, but then making every attempt to get the tube in at first attempt.
Yeah.
So in ICU, we have most of the time urgency rather than emergency.
Yeah. So, Bharat, I'd just like to add, I think Dr. Divatia touched on a very important point. So, first pass intubation, not having first pass is associated. So indirectly, it's kind of the same thing. That when you don't have first pass, you have high risk of complications. So I think the emphasis on the, getting it right the first time is so important. And this is a combination of optimizing to reduce the complication, optimizing the patient, which is very important, and using the right tools and drugs, and also increasing the experience of the operator, increasing the skill level of the operator. I think the combination of these can increase your first pass intubation success, and that should be the goal, to try to get the tube in at the fastest, as possible.
So indirectly, Sheila, you want to say that actually optimizing the patient before going for intubation is very important.
Absolutely.
Whenever
Absolutely.
possible, yeah.
That's the most
Whenever
important.
Dr.
So
Madhuri?
it's never so urgent that you have to immediately do it. You can always pre-oxygenate. You can always give some drugs. You can always optimize the a bit of the physiology before you altered physiology before you just rush for an intubation. That's what I'm trying to say.
Madhuri, you have to unmute yourself.
Wanted to add that this tussle between getting the tube in the first pass and the physiological problems in the patient, this came to light more during the COVID, when the COVID pandemic started. And the first few days when we were all busy intubating the patients, that time everybody became very much aware about the physiological derangements in the patient, which can lead to cardiovascular collapse during intubation. On so one hand, we wanted to get the tube inside at the first attempt, and on the other side, the physiological derangements were playing havoc with us. Just wanted to add that.
But
Yeah.
Yeah,
in COVID,
absolutely.
it was
Yeah.
different. The physiological derangement were more of because of hypoxia.
Hypoxia.
Come to, yeah.
True, true,
So
true.
I
But
was
they were there.
here
Hmm.
as Dr.
I want to add
Jagiasi
just one
True,
more
true.
point.
But
Can I
they were
just
there.
step in?
Physiological derangements were there, maybe due to whatever reason.
Yeah,
Yeah.
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 So, Bharat, can I just add a little
Answer,
bit
please.
over here?
Yes,
So
yes.
since we're talking about COVID, I think one of the problems during COVID was people are very reluctant to intubate for various reasons. One is that a lot of non-anesthetists were involved in the care, a lot of MBBS and even non-MBBS people are managing these patients.
Fear of infection.
And there was they were afraid of getting infected themselves. They were afraid of intubation in general. They were not very familiar with intubation. So non-invasive or HFNC or whatever was just prolonged and protracted. And intubation was attempted when the patient was about to collapse. Okay, when the very, very last sort of thing. And that's why that tremendously increased the incidence of complications of intubation during COVID. But that's a different scenario. We won't talk about it now.
So as we spoke about the physiological variations and physiological complications, what we look into, so what classic ICU nightmare is severe hypoxia. As we discussed about here, the situation can't be the urgency, is an emergency. Sir, Jiggy sir, what is your go-to pre-oxygenation technique? An IV, HFNO, or as Dr. Sheila spoke about in a talk, face mask are out. What about the NRBM, and why is that?
So I think all the principles have been very nicely covered by Dr. Sheila in her talk. So I'll just say practically, again, a lot of patients are on NIV anyway before we start intubating them. But even if they are not, if the patient is quite hypoxic, then I would definitely go to non-invasive ventilation. Okay. Patients who are less sick, maybe you can give high flow nasal oxygen. But a patient who's got a PF ratio of 150 or below, I think NIV would be better. Okay, for pre-oxygenation. The sicker the patient, then you might actually want to go for a combination of high flow nasal oxygen and NIV, and and continue the high flow nasal as an apneic oxygenation during your laryngoscopic procedure as well. So what the Ferrari 2 has actually shown us that the sicker the patient, the less likely, the more effective non-invasive is compared to the other techniques. High flow nasal oxygen works well for moderately sick patients for pre-oxygenation, continued through for apneic oxygenation during laryngoscopy. For the sicker patients, non-invasive ventilation to increase the FRC during pre-oxygenation, and then continue high flow nasal oxygen during the apneic phase. I think that would be the. Having said that, if neither of these are available, please use high flow non-rebreather masks and AMBU bags. Some pre-oxygenation is absolutely vital, but non-invasive stands out for sick patients.
So when
Just
you say, yeah.
Well, just one comment I want to add. A lot of people think that when you give non-invasive, we mean a special machine to give non-invasive ventilation. So it can just be a regular ventilator circuit onto the ventilator onto which you're going to put the patient. You can just use pressure support and PEEP. So use the same mask and the same circuit which you're going to hook the patient onto when you intubate him, and just use some pressure support and PEEP, and use this for pre-oxygenation. So, often when I talk about NIV, people say, oh, we don't have an NIV machine, or they think it's a separate BiPAP or CPAP machine. I just want to clarify that.
But most of the machines, they have an NIV system there.
Yes.
Most of the ventilators.
Jiggy sir,
Even if they don't, you can just use the pressure support.
When you spoke about the sicker patients, do you mean sicker in terms of lung injury, hypoxemic, or the sicker in terms of the hypertension and shock? Yeah.
No, no. When we are talking of pre-oxygenation, we are largely talking
Oxygen.
about lungs.
Oxygen.
So how would you
PF ratio.
tailor?
What is Bharat? What is seen is what they've shown in the Florali 2 at least was when the PO2 FR2 ratio is less than 200. So we're talking about moderate to severe hypoxia. In those patients, NIV was superior, and what was even found with the meta-analysis done by Bram that in the sicker patients, so obviously SIR means that patients with low P2F ratio, in those patients NIV is superior to high flow nasal oxygen.
Otherwise, in non-ARDS patient or the PF ratio is more than 150, 200, we can get away and do with the mask.
Yeah. So, yeah, Bharat, let's put it this way. If your patient has sort of Guillain-Barré,
Yeah.
okay, and he's got normal lungs, I mean, you get away with even oxygen face mask and non-rebreather mask, or maybe high flow nasal oxygen. But if you're talking of patients who got a bad pneumonia, who got ARDS, then you're looking at see where the FRC is reduced to start with because of the disease process, non-invasive is superior, and a sort of index of the reduction in FRC is your PF ratio. So if your PF ratio is less than 200 or 150, then you're better off using non-invasive ventilation. And when I say non-invasive ventilation, I mean you're giving PEEP and you're also giving positive pressure support ventilation.
So one more point is if the patient is already on a high pressure, I think it is no point on going for a bag mask ventilation then and coming for a mask ventilation. So I think that will not be there. Whenever the patient is, whatever the patient, if the patient is already on an NIV or an high flow, I think he should be maintained with that same system, and then for that would be an pre-oxygen for the patient. You cannot bring back the patient on a bag mask ventilation and maintain that same pressure which the patient was already having.
Yeah,
So
let me put it this way, Mohit. Dr. Mohit, I think you're right, but let's say the patient is on high flow nasal oxygen, but his PF ratio is now less than 150. He's getting worse. He's getting more hypoxic. That's why you're intubating him. Then I would definitely stick on NIV for this patient.
Yeah, that's what I'm saying. So, yeah, you can change over to NIV.
I think what Mohit is trying to say is either high flow or NIV, but we should not go back to conventional oxygen therapy. That's what he's
exactly. That's what I was saying.
Nicely summarized, and this is the point I was looking into. So this is more of a patient who has a PF ratio less than 200, 150, because in the corporate setup, as ma'am said, machine could be the same, but we had to open up the mask or maybe open up the system. So it's for specifically for the patient where the PF ratio is less than 200 if we have to take the cutoff, and that was the point I was trying to look for. And nicely summarized by all of you. We'll move ahead with the next question. Professor Mohit, this is for you. So we talk about the apneic oxygenation, which is widely being promoted, but in critically ill patient, is it truly effective or somewhat overrated? Does it really make a difference in critical care patients?
See, actually, when we say apneic oxygenation, primarily what we are trying to say is when the patient is apneic during the period of when you're giving muscle relaxants to the patient, and then when you're intubating. During this period, there is a term. This is the time when the patient is not having any oxygen if you're not giving any oxygen to this patient. So the concept of aventility mass flow came in. So even if the patient is apneic, you can give oxygen to the patient through this aventility mass flow system, means the concept. And this is primarily what we are trying to do is we are trying to buy some time, more time. The apnea time will be prolonged, increased, because we know that because in intensive care unit, we always say the patients are really difficult to intubate. We anticipate it is a difficult intubate. Even if we are assessing the patient, we always keep in mind that this patient can be a difficult intubation. So naturally, we might not be able to, pass the tube very fast or early as we are discussing. So we need to have some more time so that before the patient goes to hypoxia, and already the patients are already in an compromised lung reserve. So naturally, we need to, and most importantly, always keep this in mind that when we are talking about apneic oxygenation, we should always see that the patient had a very good pre-oxygenation. And then only we'll have at the same time the airway patency is there, and then only we'll have a very good pre-oxygenation to this. Apneic oxygen to this patient. And the two devices which we have, the two techniques which we have are primarily the no decide technique and the Thrive technique. Both the techniques are very good for in these situations. But even if you don't have, you can go with the no decide technique, which is by giving an oxygen of 10 to 15 ml per liter, liters per minute. So my point is, even if the patient is apneic, you need to oxygenate this patient so that the patient does not go to hypoxia, and it prolongs the apnea time. And that is the concept is through aventility mask. So this is very useful, and the recommendations we have seen the lot of review articles we have done in our recent guidelines. We've gone through that, and we've seen that it's a best practice statement which is being there. It is level 2A recommend. Evidences is B, and level 2A recommendations are there. So naturally that is good for us, and we think we should have to go for critically ill patients as well.
Nicely summarized. Now we move towards a different section over here, that is a hemodynamic and drugs of choice, what we use. And Professor Sheila, you've done lots of work, and I know the ongoing work is also, you're going to come up with some papers. So how aggressively should we be optimizing hemodynamics? We often see peri-intubation crashes, and do we need fluid vasopressors or both while intubating the patient or before? Any triggers or thresholds you can speak of? You have to unmute yourself, ma'am.
Yeah, I'm sorry about that. I think this is a very, very relevant question. And I feel this is really the most relevant in critically ill patients. Now, seeing the high incidence of hemodynamic collapse, you have to do something. And as I mentioned, I'm not really convinced that fluids also don't work, because most of these patients who come to ICU, they come in septic shock. And, it's a distributive shock. There's relative hypovolemia. So they may need some amount of fluids and vasopressors, or probably both. So, the two trials that have done, the Prepare 1 and Prepare 2, used fluids, but there were a lot of limitations in those trials. They looked at the incidence of hypotension or cardiovascular collapse 2 minutes after tracheal intubation. And that I feel is erroneous, because we know there is a pressure response to laryngoscopy, and that lasts. So that can keep up the blood pressure, and the fall in blood pressure will happen much later. So, a lot of things in those studies, there were a few limitations. So I'm really not convinced that fluids also don't. So I think to be fair, I think it's a combination of the two things, but we have to do something prior to prevent this. A real good tool in our armamentarium is an echocardiography machine, because at the time when you're doing this, you don't have any lines in, you don't have an arterial line in, you can't look at a lot of, it's just clinical assessment of the hemodynamics. So echocardiography can give you a good idea. Unfortunately, assessing fluid responsiveness is not easy to do, because when your patient has acute hypoxemic respiratory failure, and each breath has a different tidal volume, looking at your IVC diameter and all that is not very good. But at least a quick cardiovascular assessment, you have kissing ventricles, this patient is very, very hypovolemic, or you look at lung ultrasound, you see a lot of B lines, then I'd be cautious about giving fluids, and I might go up on vasopressors. So I think if you have some time, a quick assessment using echocardiography can help you. And of course, the results of these trials will tell us whether there is a role of starting the low dose of vasopressors, because see, that is also not without risk, because you are giving the vasopressor and you might cause hypertension. And there's laryngoscopy also, which will further, the pressure response to laryngoscopy, that might further increase the blood pressure. So you have to be very careful when you say low, how low is the dose? There's been no precedent or no, this thing about how low you should go with your dose. So what we did is, when we took patients who had regular arterial lines, who were already on invasive arterial and we looked at what is the minimal vasopressor dose that results in a change in blood pressure, that can increase the blood pressure. And that's how we titrated, the doses for the trial, and decided on 0.08 microgram per kg per minute for this. And we also saw that how much time when you give from a peripheral line does it take for the blood pressure to increase. Because see, when you give from the central line, the effect is immediate. So we saw, when we did some pilot studies, and we saw the cases, and we saw that it takes on an average about 8 minutes for, when you give for a peripheral line as an infusion, it takes about 8 minutes for the action to come. And this is why we said that at least 10 minutes prior, you start this vasopressor. Because if we start just before intubation, we may not get that effect of the vasopressor. So there are a lot of things that we have to really consider. And this is a huge area of research. And I'm hoping that the results of these trials will give us the real answer as to whether there is a role of giving low dose of vasopressors in these patients.
You very nicely summarized, and mainly, as you rightly said, we don't know about the triggers and the thresholds, how low is the low and what level we have to maintain. Also, we need to be worried about the pressure response, what is going to come up with the laryngoscope. But what about the drugs? What we should be using? Is it about like ketamine, etomidate, ketofol? Every intensivist has their own favorite. So, what do you choose in stock, and what
So,
evidence?
I follow this literature very carefully. And the recent randomized, as I told you, the meta-analysis, there have been 4 or 5 meta-analysis. That's how many trials there have been, have really shown no difference. But the current one showed less hypotension with etomidate, which was interesting. And I reviewed another paper which just got published in Intensive Care Medicine, which showed more hypotension with ketamine. So it's really interesting, this ketamine versus etomidate. But for me, the important message is that use either ketamine or etomidate, whatever you have available, rather than use other drugs like propofol. And a lot of physicians, they're very nervous to use any of these drugs, and especially muscle relaxants. So they'll use a little bit of fentanyl, a little bit of midazolam, and again, those drugs could also cause hypotension. So we have to be a little careful. So we really don't know which one is superior. And in different parts of the world, different drugs are available. So in ketamine, we have both, of course, but ketamine is cheaper for us. I've gone to some parts and spoken in the world where etomidate is not available, and I've gone to some parts where ketamine is not available. So I always say that whatever you have available, use it, but avoid using drugs that can cause hypotension. Now, ketofol, anesthesiologists especially are very fond of using this. And, because so you can have the beneficial effects of propofol, and you can use less ketamine, and you see, but this preparation is neither standardized and nor is it like an FDA approved drug, so it's more like a jugaad that people do, but really no scientific evidence to really recommend that you should use either this preparation of ketofol, this mixture for tracheal intubation in the critically ill patients. So I would say until such time that we have more evidence, we should move to using ketamine or etomidate unless contraindicated as an induction agent.
We should be avoiding. Yes.
Yeah, Sheila, I just had a point to ask you. Do you think a position of the patient can have some role in this hemodynamics as well? Because when we talk about giving some, when we're talking about in anesthetic agents like propofol, so
Yeah,
do you
that's a
think
very,
that?
very interesting question, because yes, usually when you have a patient in shock, you keep the patient head low. But in this
Yeah.
kind of patient, you want to keep the head, because it's a fine balance between the respiratory complications and the cardiovascular
What
complications.
about putting the leg raised?
So leg raise, well, not really. So I would rather offset this by using fluids and vasopressors rather than doing any of that. I would still give propped up position, because in this position, one, patients are more comfortable, and second, the posterior portions of the lung are more prone to atelectasis when you keep them absolutely flat. The patient comes and he's sitting up, he's leaning forward, and we make him flat. Again, he's leaning forward because that's the position he's comfortable with, and we make him flat for intubation. So I think at least 20-degree elevation, as we have recommended in the guidelines, for pre-oxygenation, and the semi-fowler position, or the HELP position, like you say, the head elevated laryngoscopic position, where the face is absolutely parallel to the ceiling, and you try to align the external auditory meatus with the suprasternal notch, and especially very important in obese patients, where you can ramp them up to achieve this alignment. So it's controversial, sniffing position versus other positions, but definitely the head elevated position can be beneficial in these patients. And I would not, even if they're in shock, try to give any head low or raise the legs or anything like that in these patients. But that's interesting. Your question is very interesting.
Yeah, sir wants to say something.
Jiggy, sir.
Yeah. So Bharat, I think the bottom line is avoid propofol. I think in any form, whether in combination with ketamine and all that nonsense, don't do it. Avoid propofol in all forms in the ICU when you're intubating such patients. Like I tell some of my anesthesiology friends that leave your propofol behind and then come to intubate in the ICU. But I think the other thing, we need to be very mindful of the dose that we use. For example, ketamine, we've written here 1 to 2 milligram per kilo. But sick patients, and when I say sick, I mean not just hypoxically sick, but even, blood pressure-wise sick or semi-conscious or something, may go under with 0.25 to 0.5 milligram per kilo of ketamine.
So titrate to effect.
So please don't use standard anesthetic doses of these drugs, whether it's ketamine, whether it's etomidate, just use small doses first, and then you can sort of give the minimum dose which produces the sort of effect that you do. A lot of people will attempt to use midazolam prior to ketamine or midazolam along with fentanyl. But also please keep in mind, especially in sick, hypovolemic, septic patients, a small dose of midazolam, 1 to 2 milligrams, can also produce profound hypotension. So I think just be mindful of the fact that many of the so-called cardiostable drugs are not very stable when you use them in these patients. Ketamine, all doses should be given in the minimum dose that produces the effect. So titrated doses are extremely important. Don't use standard bolus doses of these drugs.
Yeah, a very important point made by Dr. Vatia.
Really
And you
kind of-
titrate to effect. And the other important thing, so there is a trial that's compared ketamine versus ketamine and fentanyl. Because a lot of people give fentanyl and then they give ketamine. And they have shown more hypotension with the combination, of ketamine versus fentanyl. So I just wanted to tell you about that.
We'll take one question from the audience as well as Dr. Gayatri, ma'am, is relevant to this. So she's asking, could you please comment on intermediate induced adrenal suppression in critically ill? And we had spoken about the septic shock not being.
Yeah. So this has always been a concern. In fact, at the Lancet paper that came 20 years back, after which we changed our practices to ketamine and etomidate, showed more adrenal insufficiency in these patients. And that has always been a concern because, of course, we know these patients have sepsis and patients in septic shock, and we're concerned about that. But interestingly, over the time, the large trials which have compared ketamine versus etomidate and specifically looked for this entity with etomidate have not been able to demonstrate any increased incidence as compared to ketamine. So it may, even a single dose can cause this effect. So, of course, you're worried about it, but, it seems like it's not as much as a concern because the trials have not demonstrated any further complications with etomidate. And in fact, if you look at the meta-analysis that has just come out, there is less hypotension with the use of etomidate. So it really confuses me a bit as to which one is superior. In my mind, both are equivalent, and you shouldn't worry too much about these concerns of adrenal insufficiency in critically ill patients with the use of etomidate when you're just using it for induction, a small dose.
So this thought of intermediate induced adrenal insufficiency is overrated, and we don't actually
Yes.
see the clinical practice.
Not shown in trials, at least, to be a concern.
And there's one more question from the audience, is Dr. Manish Chaudhary. Jagisa, it's for you. When he spoke about the HFNC versus NIV, he's asking, can we use ambu bag mask ventilation? Is it equally efficient or?
We already discussed about this.
No, I don't think so. I think now I just want to make it clear. So when you use an ambu bag for pre-oxygenation, you put the mask with the ambu bag and you have a reservoir bag. So that gives close to 100% oxygen with the flow full on, and the patient is breathing spontaneously. So this is a similar to a non-rebreather mask pre-oxygenation, and it is not as effective as either high flow nasal oxygen or non-invasive ventilation.
No PEEP.
PEEP, no pressure.
Because there is no
Pressure.
CPAP which is coming up over here. Now, if in this state he wants to give positive pressure ventilation, I'm not sure, it's never been tried out. We feel we are doing some positive pressure, but it has to be very well synchronized with the patient effort. There should be no gastric distension. So I think this is not a great thing to do. On the other hand, after you give a muscle relaxant, if you give positive pressure ventilation with the ambu bag and mask and a reservoir bag, then that helps in maintaining oxygenation. Okay, so before you make the patient, so after the patient has become apneic, while you're waiting to sort of get your laryngoscopy and all that ready, you are giving positive pressure bag and mask ventilation. That is good. That can be given. And I think Dr. Sheila mentioned a trial which compared no bag and mask ventilation versus bag and mask ventilation. Bag and mask ventilation was definitely superior to this thing. So for ventilating after muscle relaxant till you do laryngoscopy, yes, as a method of pre-oxidation, inferior to high flow nasal oxygen and non-invasive ventilation. But if that's the only thing you have, please do it. Don't say, I don't have non-invasive ventilation, I don't have high flow nasal oxygen, so I will not pre-oxygenate. Yeah, please.
I just want to add that actually I missed showing that trial, but it was a very controversial trial because in classical RSI, we don't do gentle mask ventilation. But you must understand one thing that, when we do an RSI, the reason we do it is to prevent aspiration. So when we advocate gentle mask ventilation, you have to think on one side, there is the perceived risk of aspiration because, the fun is they might be full stomach. So the second thing is critical illness itself. There's a gastroparesis of critical illness. So by default, all critically ill patients are considered as full stomach. Now, in this trial, they excluded patients who were at a high risk of aspiration and those who were, having a full stomach or whatever. But what they found is that when they gave gentle mask ventilation, the oxygen saturation all was better, and they didn't have any increased risk of aspiration. Of course, this trial was not powered for aspiration. But if you look at it, on one side, the perceived risk of aspiration, and on the other side, there is a huge risk of desaturation. These patients have pneumonia, ARDS, etc., and they have desaturation, bradycardia, cardiac arrest less because of that. So it's a risk-benefit ratio that you have to look at. So I would say in those patients which are at a low risk of aspiration, but at a high risk of desaturation, you should definitely give gentle mask ventilation during the RSI.
We'll move ahead to the next question, Dr. Tanmay. Are you around? It's for you. So we talk of delayed sequence intubation, and it sounds ideal in the book, but in real ICU practice, is it feasible, and or does it complicate things? So,
So, sir, actually, so the delayed sequence intubation actually means when you're actually not performing the rapid sequence induction and your patient is quite agitated, you want to buy time for pre-oxygenation. So it is basically reserved for the patients who are very agitated, and there is a increased risk of hypoxemia in these patients. So you want to try to give ketamine and you just try to wait so that there is a dissociative anesthesia, and it leads to some kind, you buy the time and you try to oxygenate that patients. But it is easier said than done. It is sometimes it can increase the complexity and increase the risk of aspiration in these set of patients. So when you navigate for a delayed sequence intubation, you have to assess and you have to optimize and you have to judge your clinical skill whether it can be accomplished in those sets of patients or not, sir.
Yeah.
So my point would be, sir, it increases the complexity. When you are trying to do for a delayed sequence, it is not that you can always be on first hand be able to achieve that. So you have to be a quite well versed with the art of delayed sequence intubation, sir.
I just like to add one point. So this is basically for those like Tanmay has rightly said, the rowdy hypoxic patients, the ones who need the oxygenation the most, but it's very difficult to achieve. So all
Yes,
you're
sir.
doing is you're giving very low dose of ketamine, like sleep doses, 1 milligram per kg, and calming the patient down and then pre-oxygenating him. And sometimes, these patients, you look at them, when you look at them, you think, I need to intubate him right now. But after you do, and this is done a lot in the emergency department, very underutilized in our ICU.
Underutilized.
And when you do this, it's a very easy technique to do. And when you calm them down, you pre-oxygenate them, sometimes these patients don't require any intubation. And even if you want to do an awake intubation, say in an anticipated difficult airway, anatomically, this is a good way to do and use a flexible bronchoscope to intubate. And then, of course, after you do the DSI, you proceed to do an RSI. So you have three options, either not to intubate at all, or to do an awake intubation, or to do a RSI. So DSI is not anything to do with intubation. It's a method of facilitating pre-oxygenation.
Delaying.
Yeah.
So we'll move ahead, and because we have a slide ahead where we'll talk about the RSI, modified RSI, and the DSI to be next with the discussion. So, Professor Mohit, should video laryngoscopy be the default first attempt in all critically ill patients, because video laryngoscopy has become ubiquitous these days? So, what is your take on this? Are we overusing it?
No, definitely not. Actually, I think video laryngoscopy is the need of the hour, especially in intensive care unit. And we have been speaking since evening regarding video laryngoscopy and first pass intubation. And we know that video laryngoscopy definitely has a major role, especially when we talk about first pass intubation, and it helps it. And why we are talking about first pass intubation, Dr. Dwivedi has rightly very said that we are trying to prevent complications as well. The more you try to give it, you go on attempting, number of attempts will also cause your, complications more. If you're taking more time, then it is also causing hypoxia and causing more, it can cause complications as well. So first pass, a lot of studies we've done around 283, literature studies we have searched, and most of the literatures we found that yes, the delayed, direct video laryngoscopy is always obviously a preferred technique for intubation. But of course, if you are really, if the operator is not very convinced, not very experienced on video laryngoscopy, and he is very convinced with a direct laryngoscopy, he has always a chance for direct laryngoscopy. That's not a big deal for him. But at the same time, you must also see certain advantages, especially in an intensive care unit when we talk about video laryngoscopy, especially the patient's position, the patient's bed when we are intubating, the situations at which we are intubating the patients, and the disease process. Supposing the patient has cervical fracture, In that situation, obviously, video laryngoscopy, we not do for, as Dr. Sheila was very rightly saying, that sniffing position will not be a choice in those patients. So morbid obese patients, again, video laryngoscopy will have a very good role to play, and first pass intubation will be always will be higher in these situations. So we've gone through, as per the literature and the recommendations which have done in our guideline. We've given an recommendation one, and level of evidence is around it's a level of evidences. So naturally, after the literature search, we have seen that it really has a very strong play in the care unit as well.
But in the talk what Dr. Sheila delivered, she said in the anesthesia room it's been proven, but when it comes to the ICU, it doesn't have any benefit.
No, actually, now it has. No, we have a big trial that
now
is.
the recent study, I think Sheila at the end, she has shown that recent study when she said that yes, this is with the meta-analysis. She has shown the proof. Yeah, with the meta-analysis, she has shown that yes, it's a really good role.
The point I was making is that the experience of the operator matters. So it's not just about buying a video laryngoscope, but teaching people how to use it effectively to deliver the tube.
Yeah, that's why we have said also that if the patient if the operator is not experienced enough, he might he can go for direct laryngoscopy. But as per the recommendations, we always would like to go for video laryngoscopy as the first choice.
And I think, Bharat, if I may just come in over here.
Yes, sir, please, sir.
So I think if you're using a video laryngoscope, all the more reason to go upfront with a stiletto or a bougie. Okay, all the more reason. If you're using a hyperangulated blade, now you know there are different types and types of video laryngoscopes. But if you're using a hyperangulated blade, it is mandatory to use a shaped stiletto. Even if you're not using a hyperangulated blade, you're using a Macintosh type of standard type of blade. Again, it is well worth it to use a stiletto upfront in your very first attempt at intubation. That helps to clear a lot of problems with intubation, whether it's with a direct or a video. And I think if you've got a video, you should train your residents to do video laryngoscopy, and everyone should be trained to video laryngoscopy. And it makes a big difference, not only in the ease of intubation, but also for someone else to see where your tube is going in, whether your tube is going in front or it's going behind or it's going to the right place. It just like, the whole ICU can see that you're intubating in the right place.
So I just want to add a point, Doctor. I missed saying this in my presentation. So very important point about, so there have been the use of, we usually use a bougie or a stillet as a rescue. So they have used a bougie or a stillet during the first attempt at intubation, and they have shown increased first pass intubation success when a bougie or stillet was used compared to when it was not used. So a very important message for intubating critically ill patients, that you should use a bougie or stillet during the first attempt at intubation and not as a rescue during the second or third attempt.
So as you also said in the talk, and sir also brought it out, video laryngoscopy, everyone can see what is happening, and you have guidance from all across the corners, which is very difficult in the classic laryngoscopy where someone is over the shoulder and just trying to see through it, and it's difficult to. But sir is as giving the daily tips as of today. It's very important to use this stiletto.
In fact, you don't need to tell your assistants what to be done, because he himself sees it and he knows what is to be done. So naturally, he gives you a ready-made. So it's just like an assistant which is being helped.
So we'll move towards next question, that is about in a crashing patients. We discuss about this when we talk of determining what is the choice between RSI, modified RSI, and we already spoke about the DSI. So ma'am, you're making a point over it. This for Madhuri. Madhuri, you can take it, and then Sheila ma'am can make it.
Yeah. So in a crashing patient, what will I choose? Whether I'll choose rapid sequence induction, modified rapid sequence induction, or delayed sequence intubation? That is the question. So here, three important factors should be taken into consideration. One is the hemodynamic status of the patient. Secondly, the oxygenation and the airway. And the third is the mentation. What is the level of consciousness of the patient? And is he agitated? And what is the risk of aspiration? Now, if the patient is relatively stable and hemodynamically he appears okay, then you can go in for a rapid sequence induction. Whereas if he's unstable, he is in shock, not very hemodynamically stable, then you can go in for a modified rapid sequence induction. Whereas if he's agitated, non cooperative, and severely hypoxemic, then we can go in for the delayed sequence intubation. So, much has been already spoken about delayed sequence intubation, but I would just like to add here that we have talked about ketamine, giving ketamine for delayed sequence intubation, but there are new studies which have come up with using dexmedetomidine for delayed sequence intubation. Though the onset of action is a little bit slower than ketamine, it is emerging as an alternative for delayed sequence intubation, mainly because it produces sedation without respiratory depression.
So I
So
just want to
maybe
add
it
a
can
point
be used.
here.
Maybe it can be used as an alternate. I don't know. Like you
Yeah,
can
so I just
elaborate on.
want to add a point here. Yeah, so delayed sequence intubation classically is described with ketamine because it
Yeah.
doesn't produce respiratory depression and because of the hemodynamic stability. The
Yeah.
concern with dexmedetomidine, as you rightly said, the time taken and also the hemodynamic side of
Hemodynamic
it,
stability.
bradycardia and hypotension.
Right.
So
Yeah.
not
Yeah.
very suitable for this. Of course, there are
Maybe it will not.
studies, but the classic DSI, and again, DSI has nothing to do with rapid sequence intubation.
Patient.
It is just giving sedation to pre-oxygenate the patient. It is not a RSI technique. So, we should not mix these two things because DSI is called DSI, so people think it's something to do with
It's
RSI. But
primarily
actually,
It has
it is just
modified the
giving
RSI,
calming down.
modified RSI for intubation.
exactly.
It
Yeah.
has to prep the patient for intubation.
Yes, calming down an agitated patient. Primarily, it is that,
Yeah.
basically.
So in ICU, most of the time we would be doing modified RSI than the RSI. RSI is for the
So, with modified RSI, the thing is, when you say modified, what is the modification? So, the modification is that you may not
Ventilation.
be using cricoid pressure. You may be giving gentle mask ventilation to these patients, which I just talked about. So, not all patients will get the gentle mask ventilation, but you're deviating away from the classic RSI where,
throat section as well.
you don't ventilate the patient between the time of giving the muscle, induction to the time the tube is inside, and you always give a cricoid pressure. So these are some modifications that you may consider in these high-risk patients.
So, Bharat,
Yeah, but
another feature of the modified rapid sequence
Yes, sir.
is in a classic rapid sequence, you give a fixed dose of an induction agent.
Yeah, that also.
And
Titrated
like we
Titrated.
discussed earlier, in a modified, we would want, especially in a sick patient, critically ill patient, we'd want to give
Titrated doses,
small
yeah.
titrated. So the induction period may be prolonged. Remember, if the patient say has got cardiogenic shock or he's got heart failure, right? Then his arm brain circulation time will be very long. I know it's not 25 or 30 seconds, maybe a little much more than that. So if you give a little small dose even of ketamine, you have to give it time to reach the heart when the circulation is very sluggish. So in a classic rapid sequence, when you just give that 1 milligram kilo and forget about it. But here you'd give a little bit, wait for it to act, give a little more, wait for it to act. So be a little patient and then sort of do it. So that's the other difference.
Yeah, titrate to effect, yeah.
Rapid sequence intubation.
So, Jagisa, this is for you. So, in a critically ill patient, we all know we reach a stage where we cannot intubate and cannot oxygenate a situation. So, what is your personal threshold for declaring failure and proceeding to FONA? And then I'll have the follow-up question as well. And how do you avoid delaying the decision?
So, Bharat, as one of the authors of the All India Difficult Airway Association guidelines, I want to upfront say that these two terms that you highlighted, kaiko means kashala, kyon, SIH, and the other one is FONA, front of neck. I mean, whoever does an cervical epidural or does a tracheostomy at the back of the neck. So the All India Difficult Airway Association does not use these terms. So
not only the All India Difficult Association, even the Puma group has moved away from these terms, kaiko and FONA, because they're abbreviations. And in an emergency, you should use, you should not try to abbreviate the terms. So even for the Project for Universal Management of Airway, we do not use terms kaiko and FONA. But despite that, Indians love to use kaiko FONA, and they follow
I think we are still slaves of the British Empire.
Yeah.
So
We have good terminology, so we should use emergency cricothyrotomy rather than use FONA, because we're talking about an emergency situation. And when we say cricothyrotomy, we are also giving a focus on which is the anatomy that we're targeting.
Where exactly
And
it is.
though FONA is very dominant in the literature, in clinical practice, and this is all published, that emergency cricothyrotomy is dominant in clinical practice. The dominant terminology, critical language in clinical practice.
Even surgical airway and PCT, they are also front of neck access. How can you say it's an emergency cricothyrotomy? The term is wrong. I mean,
Yeah,
so now to the real question here.
So when do you say that you got this cannot intubate, cannot oxygenate? It's basically when you're unable
What
to
is the
ventilate the
threshold, sir,
patient.
when I think of doing a surgical?
So you paralyze the patient because you've given a muscle relaxant, and now you're not able to get a tube in. You're also not able to get, say, a supraglottic airway or some other means of ventilating the patient when he's paralyzed. You're also not able to do face mask ventilation. In other words, you've got a situation where all your avenues of getting air into the lungs or oxygen into the lungs or ability to ventilate the lungs have failed. Okay, so we call it as a
complete ventilation failure.
So we call it complete ventilation failure. So you can't intubate, you can't give ventilation via laryngeal mask or supraglottic airway, which is a rescue device. You can't do face mask ventilation. So that is a stage where you're in a deadly soup because you've paralyzed the patient who's not breathing and you're not able to give him any breaths by any route that is available to you. And to me, that is the trigger to call for help and do a emergency cricothyrotomy. It doesn't matter what is the saturation. And this is a big problem with this cannot oxygenate terminology, because people assume or think that cannot oxygenate means we have to wait for the saturation to fall to some level before we think of a cricothyrotomy. But the moment you are not able to ventilate by any means, even if the oxygen saturation has not fallen, the oxygen saturation will fall. And the fact that you're not able to ventilate the patient by any means is your trigger to do an emergency cricothyrotomy. To call
It's
for
a safer trigger. It's an early
trigger.
Emergency cricothyrotomy.
So I think we should move to saying complete ventilation failure and emergency cricothyrotomy.
Shout emergency cricothyrotomy so everyone knows exactly what you want to do.
Sir, the technique, can you tell which technique, the surgical cricothyrotomy?
So I have a question from the audience as well. Which technique? Scalpel first technique universally, or there's a roll of needle?
Because earlier we had recommended either technique, whatever you're familiar with, because people didn't transition from upper airway to neck rescue, which was, they used to delay that. So we said, whatever technique you're familiar with, whether it's surgical cricothyrotomy, needle cricothyrotomy, or you're using commercial kits like the Cook Melker or whatever, use whatever, but please transition to doing a neck rescue, transition to doing emergency cricothyrotomy. But now the evidence has evolved more towards using a surgical cricothyrotomy. And so even the IDA guidelines and the DAS guidelines and all recommend a surgical cricothyrotomy. Of course, you can do the other techniques. You have to do something. But surgical cricothyrotomy is recommended over the other techniques. And we use a scalpel, bluegee, and tube. And it's very good for the Indian scenario setting, in any resource-limited settings as well, because a 10-blade scalpel, 6-number tube, and a bougie would be available universally in India. So scalp, and in the in the ICU, you cannot use needle cricothyrotomy, because remember, it's not about sticking a needle in. You need pressure regulated jet ventilation. It's not just putting the needle in. So that is not available in the intensive care unit. So the technique that one should use is, and be trained to use, is the scalpel bougie technique.
Unless until we have that cricothyrotomy set, it has that.
But it's superior. The cricothyrotomy sets have not shown to be has shown much success as in comparison to surgical cricothyrotomy. So today, everyone should be trained to use perform a surgical cricothyrotomy.
Preferred technique.
So anything below 6 size tube, you will always need a jet ventilator. So anything below 4, you need a jet ventilator. So naturally, there in that case, it is always better that you have a surgical technique, which is.
And also, one more point I want to make people think: tracheostomy is emergency airway management. It is cricotomy, and percutaneous tracheostomy is not at all a procedure to be done in an emergency. It's an elective procedure. One should never do a percutaneous tracheostomy in an emergency. Though there are some case reports of people having done it, it is not recommended for emergency performance.
So now post-intubation care, we often celebrate successful intubation, but the danger doesn't end there. So what are the Jiggy says for you? So what are commonly missed post-intubation killers in ICU?
So, okay, so let's put it this way. You've confirmed that the tube is in the trachea. Okay, but the tube may be in the trachea, in the airway, but it may be further down. So it may be in the bronchus. So you may get hypoxia just because you got a right epibronchial intubation. So you need to watch out for that. And okay, that's one. The second thing, like we've discussed, we need to watch out for cardiovascular collapse because that's going to could happen in the next few minutes. So you need to make sure that your vasopressor is actually loaded and ready to go if it's not going already. Okay. The third thing is you need to make sure you've got adequate sedation for the patient because you don't want the patient to be waking up and pulling out tube and self-extubating and stuff like that. Very importantly, you need to take care of infection because infection control is going to be very good. And, so make sure you got your HMEFs and your circuit is this thing and you're handling it in a reasonably clean and aseptic manner. And then, of course, you need to do your something like a fast hug and make sure you got all your basics right over there. But I think in the immediate sort of thing, prevention of infection, prevention of cardiovascular complications, watch out for hypoxia. Obviously, take a chest X-ray if to make sure where your tube is, or you do a
Protective
lung
lung ventilation.
and see whether you've got lung sliding on both sides. If you put a nasogastric tube at the time of intubation, which is a good idea to put a nasogastric tube if you haven't put one already, make sure the nasogastric tube is in the right place with your chest X-ray, and then do all those sort of things. What else? I mean, there are so many things you can sort of.
So one thing I just want to
Protective
add.
lung ventilation.
One thing I just want to add here is
protective lung ventilation. Yeah.
we have to actually, sir, one thing very rightly said, sir has said, and in fact mentioned everything. One thing is we have to think about analgesic than of sedation. So we need to give more of analgesic because the tube which is there and that is more painful than to go for a sedation. So primarily we always think about sedation, but analgesia has to be taken, should be the priority. And the third thing is the cuff pressure. The cuff pressure has to always be monitoring the cuff pressure because that is again a point which has to be kept in mind. And of course, position and position. And sir, as sir said that obviously is fast hug is again positioning the patient and every time reassessing the patient, the tube's placement of the tube, fixing the tube. There are very important small things which we have to.
And also checking the marking of the tube in each shift.
Fixing
because the tube might migrate, so that's also important.
That's every day on a daily basis. You need to see this. And of course, humidified oxygen, I mean, whatever gases you're giving, it should not be died. They are all some things which you always keep in mind. And monitoring the patient's hemodynamic status, as sir has said very rightly, everything is there. So they are very important things which you have to, small things which you always forget it. So they have to keep in mind.
So thank you. We come to the end of this session, and that was truly insightful discussion. If I had to summarize few takeaways, ICU airway is a physiology first and anatomy second.
Stop share, no?
Yeah. Is ICU airway is physiology first and then anatomy second, and preparation matters more than a speed. Also, we have to talk about the oxygen hemodynamics are as critical as the tube first, and finally, intubation is not the end point, the beginning of another critical care phase. So I would like to sincerely thank all of our panelists for sharing their expertise and practical insight, and thank you to the audience as well. Airways management is something we all do, but discussion like this help us do it better, safer, and smarter. Thank you very much.
Thank you so much.
Thank you so much, sir.
Thank you very much. Thank you.
Thank you, everyone.